This week on the BackTable podcast.
I always find it fascinating being a urologist and doing what we do. Has there ever been as much public controversy about penile lengthening, injections to make the penis, wider? That's just kind of a fact of life. Like if you want it, you do it. No one would be judgy about it. But yet if a woman wants to make her vagina more sexual, whether it's appearance or functional, or like, what are you doing? Why are you doing vaginal rejuvenation? There is a double standard. And I think that being urologists who practice urogynecology, men with prostate cancer, we give them testosterone all the time. Nobody bats an eyelash. But you want to give a woman some vaginal estrogen, even though the data shows that it doesn't get absorbed systemically because there's a black box warning on it. There's a black box warning on quinolones, I think. And that doesn't stop us from prescribing them.
The urgency is real, and we feel it. The time is now for bladder control. You're here for the hard calls, the quiet progress, and the breakthrough moments. We're here with inspired innovation, support that never stops, and trusted outcomes. Together, we build for the moments that change lives. Visit urgencyisreal.com to see how we're innovating for you and your patients. Medtronic.
Hello, everyone. My name's Nirit Rosenblum. I'm here as a moderator. I am a professor of urology and obstetrics and gynecology at NYU Langone Medical Center in New York. I'm also co-director of the Urogynecology Fellowship that we run. And I have two friends and colleagues here with me today to talk about vaginal rejuvenation. Dr. Karyn Eilber works at Cedars-Sinai Medical Center in Los Angeles. She is also professor of urology and obstetrics and gynecology. She's chair of the Cedars-Sinai Department of Surgery and chair of the Cedars-Sinai Wellbeing Committee. And she's also recently become a certified menopause practitioner, the Menopause Society. Our second guest today is Dr. Ariana Smith. Ariana is the chief of urology at Pennsylvania Hospital in Philadelphia. She's the Alan J. Wien Professor of Urology and the Director of Urogynecology and Reconstructive Pelvic Surgery. And I welcome both of you to talk about vaginal rejuvenation.
Thanks, Nirit.
I would open up by just asking you a question I get asked by a lot of patients. What exactly is vaginal rejuvenation?
Thank you, Nirit. Before we dive into vaginal rejuvenation today, I'd like to take a moment to thank the SUFU Executive Committee and the Communications Chair, Dr. Nitya Abraham, for bringing this idea to fruition. I'm really grateful for our SUFU collaboration with BackTable Urology, as they've done a really fantastic job reaching the urologic community with the important conversations that need to happen. And this is an important topic, Nirit, and I'm thrilled to be here with you and Karyn because all of us as urologic and urogynecologic providers need to have more conversations about vaginal rejuvenation, and this is a great platform to get that conversation started. So what is vaginal rejuvenation to me? Well, it's not one thing. It's a lot of different things to different people, but it really can be defined as anything that enhances vaginal tissue health. It's a broad term. It encompasses several surgical and non-surgical procedures and therapies that really aim to improve or enhance vaginal and vulvar appearance, vaginal comfort, and sexual function.
I think an important point to make is vaginal rejuvenation is not a procedure because people are asking what it is, and it's really more of a marketing term, if you will. And one of our, now she's an attending, but at the time, one of our residents, Paige Kuhlman, did a study where we polled lay people and physicians, including internal medicine, plastics, urologists, what vaginal rejuvenation was. And there was such a wide response, including things like vaginal tightening or a labiaplasty or even just injection of, the alleged G-spot. So I think, again, to reinforce what Ariana said earlier, it's really important to open this conversation because people go in saying, maybe I need vaginal rejuvenation. What exactly do you mean? And whether it is cosmetic surgery or surgery that has a medical indication, it's all in the expectation. So when people understand what vaginal rejuvenation is or is not, I think everyone, including practitioners and patients, will be much more happy.
Agreed. And I think the biggest sort of confusion that I see, kind of going along the lines of what you both said, is this a medical procedure that in our field improves quality of life, or is it cosmetic? Is it covered by insurance? Is it out of pocket? And I agree, it's a very broad term. Would you both say that vaginal rejuvenation is synonymous with a mommy makeover? What's a mommy makeover?
I would say no, not really. But vaginal rejuvenation can be a part of a mommy makeover. In my mind, a mommy makeover is really this customized surgical approach to reverse some of the changes of childbearing, and often includes cosmetic procedures for the breasts and the abdominal wall. But it may include improvements in the appearance of the vulva, or even liposuction as an extension of the abdominal wall down into the mons pubis.
I was just thinking plastic surgeons are probably having the same conversation we are about vaginal rejuvenations. What do you guys think a mommy makeover is? So it's interesting that we're sitting here guessing what a mommy makeover really is also. I don't know. For me, it's, I guess in my mind, I always assumed a mommy makeover is like an abdominoplasty. I mean, whether you have vaginal birth or cesarean, everybody's lower abdomen gets distorted by these little creatures that are growing inside of our bodies that we call our children.
Yes. And along those lines, it's not only people in our specialty who perform vaginal rejuvenation. We have, general gynecologists doing it. We have probably some dermatologists treating it with laser, and even plastic surgeons. And there's a whole field known as cosmetic gynecology, and the American Urogynecologic Society actually put out a whole bulletin of guidelines about what is cosmetic gynecology and how we define it. So maybe we should kind of delve into some of the procedures that might fall under the umbrella of vaginal rejuvenation, and whether we want to divide it up into kind of cosmetic procedures versus more functional quality of life correction. I would just ask you both sort of what would you think of as some common rejuvenation procedures that patients might be seeking?
The first one that comes to mind for me is labiaplasty. Labiaplasty is a procedure that can alter the size, the shape, the general appearance of the labia. And generally, we're talking about the labia minora, but it could really also include the labia majora as well. It's done to treat, labial enlargement or hypertrophy, which can occur after pregnancy. It can occur with childbirth, menopause, or even just from aging. And some women, they have aesthetic concerns about that appearance and the asymmetry of their labia. And they may feel like the labia are actually protruding when they're wearing tight clothing or bathing suits. So the labiaplasty can be performed to treat this aesthetic, but it could also be performed to treat discomfort. There are certainly patients that I've seen who've complained that their enlarged labia are chafing or irritating them during regular activities, exercise, or even during sex. And the excess tissue, it can be removed in a lot of different ways. There are several techniques that have been described, some of which essentially trim linearly, and others that take a wedge resection out of the central portion of the labia. But this is really one of the first things that comes to mind for me when I think of vaginal rejuvenation.
Interesting. I always wonder, would we have so many requests for labiaplasty had hair removal not become so popular? I do think that, in the past, when it was more the norm to have pubic hair than none, probably people didn't really notice as much. And also, I just think with more of the internet and people able to see other people's genitalia and nobody really setting what is a normal standard, that people are wondering, like, do I look normal or not? I think the other common procedure that would fall under vaginal rejuvenation is tightening, whether somebody really needs it or not. Unfortunately, when I say not, unfortunately, I've had women who, I think that society, unfortunately, has made single middle-aged women undesirable. I mean, that's just how they're portrayed. And I think that when these women go back out in the dating world, because they've either had the same partner for a long time and or maybe they haven't had a partner at all for a long time because of a bad relationship. I've had several women come to me asking for vaginal rejuvenation, which was really tightening for them. And for all intents and purposes, they had the most perfect vagina, but we won't say what their partner's issue probably was if they thought she needed to be tightened. But I do think that this tightening is probably after labiaplasty, you know what I'm saying, Ariana, is the most common thing that is there, right? I mean, why don't we have like penile rejuvenation? You know, it's always the woman who has to be rejuvenated. So those are, I think, between the labiaplasty, I think, and the tightening, those are the two most common requests that I would say fall under vaginal rejuvenation.
And how would you guys comment about, are these procedures often covered by insurance? Are they out-of-pocket expenses? Are they considered cosmetic? Or can they be medical or functional?
I mean, for sure, like what Ariana was mentioning earlier, especially I think with runners, if you have excessive tissue, 100% it chafes, and no question. I think also some people probably do, you know, I've had people tell me whether it's true or not, and they zip their pants if they really have a lot of excessive tissue. But then my question is, why don't you have underwear in between your zipper and your pants? But, you know, we're not judging. But other than that, I think it is sometimes difficult to get the labiaplasty covered, which if it really is labial hypertrophy and it's like a simple vulvectomy, versus most women who need a tightening, they have prolapse anyway. And really, what a lot of people don't realize is having a prolapse repair, a benefit is you get some vaginal rejuvenation on top of that. I always like to tell patients prolapse surgery is vaginal rejuvenation that is covered by insurance.
Right. It's like a DEEP or a tram flap done for breast reconstruction gives you a tummy tuck, right? So I bet there's also some regional differences, because I know in New York, I really don't have a problem getting labiaplasty covered. I do exactly what you said, Karyn. I bill it as labial hypertrophy with a simple vulvectomy as the code. But then, of course, there's others who just, you know, prefer not to go through insurance because the practitioner is just cash only, or however you want to describe it. I don't know how it is in Philly, Ariana.
I think for labiaplasty, exactly what you said holds true here as well. I think when we start talking about some of the laser or radiofrequency therapies, that's where I have not seen insurance covering those procedures, and probably rightfully so, given the lack of evidence to support some of those therapies and the claims that are made around that therapy.
Yeah, and I think that's a good segue into the topic of vaginal lasers, because many people would say that is really what vaginal rejuvenation is or should be. So maybe we should talk about the FDA indications for laser use and then what it's marketed for.
It's so interesting when we have this like kind of lack of data, and yet we know things do work. Like I am a big believer. I think the Mona Lisa really does work. I'm actually surprised that after all these years, breast cancer patients have not gotten at least indication with insurance coverage for Mona Lisa. Because even no matter what the data shows, I'm sorry, if you are a breast cancer survivor, I think you have a really hard time listening to anybody, even if we tell you that vaginal estrogen does not absorb systemically in any significant amount. I think in urology especially, we extrapolate a lot of data from other specialties. And I think there is no question that in dermatology, lasers are used all the time, you know, for tightening, for hyperpigmentation, for different reasons. And I don't think it's wrong if you're familiar with lasers and you use it that way. Having said that, you'll never get it covered by insurance, just like you really don't get it covered by dermatology. But it's interesting also how we pick and choose what we comment that is FDA approved or not. We do so many things off label. And I think that's part of being an expert and being fellowship trained and being a leader in your field. So rather than, I think, condemning the use of lasers, I think we need to steal from our colleagues what they know about the therapies and apply it in a thoughtful way and have that discussion with our patient, you know, and it's all about shared decision making, right? But I also tell patients, look, you're going to pay cash for it. If this is important to you, this is what we can do. But, you know, I think also the older I get, the less judgmental I become about plastic surgery and anything that's cosmetic.
I think that's totally fair. I think when we talk about the laser and the radiofrequency therapy, these really are two different types of therapy. Both use energy and they both heat up the surface. The laser heats up the surface really in the top layers of the vaginal lining, and then the deeper layers can be treated more with the radiofrequency therapy. And the real goal is to stimulate collagen and elastin production. And we know this works in the skin dermatologically, as Karyn said, for addressing some of the signs of aging. the claims in the vagina that they improve all sorts of things, the problem may in fact be that they're true, but the right studies haven't been done, or the right design of study hasn't been implemented. And the companies that are marketing these devices to women are making claims that probably exceed the reality of what they can do, that they really can enhance lubrication and sexual pleasure and, bring you back to a time in your life where there was not a worry in the world. I mean, I think some of these things sound kind of silly, and we know that as physicians, when we hear these claims, that they're probably not all true. But the problem is a lot of this marketing goes directly out to women consumers, and they think that this is what the laser is going to bring them. And as a result, they're willing to pay a lot of money to come in and have several sessions in the office to treat their vaginas. And, I think what we really have to mention in this space, we don't want to limit potential development, because there may in fact be a very useful therapeutic benefit, especially for our breast cancer survivors. But we really do want to make sure women are aware of the potential side effects, and that women have been scarred. There has been vaginal stenosis. There has been vaginal pain associated with the use of these therapies. And really, I think what we could advocate for is better science and really trying to understand where this therapy fits in and could potentially play a role in the future.
Yeah, I would agree. And I think one of the common misconceptions I hear from women is that it's going to enhance their sexual function. And there's a lot of marketing for that, because we don't have enough FDA-approved treatments in women for sexual dysfunction, whether it be lack of arousal, orgasm, low libido. We don't have great treatments. And so people are looking for therapies. And to them, this is a form of vaginal rejuvenation to have laser. And then maybe we can talk a little bit about what is the G-spot, and is, injecting platelet-rich plasma into the G-spot something that is considered vaginal rejuvenation, and is it potentially beneficial in any way?
I'll comment on that. It's very interesting. The G-spot, the existence is arguable. And it was really, I think, on a small number of cadavers, and these were older women, right, that it was looked for. And not to say that it's not there or something, but if there was a consistent G-spot in every woman, I think we'd have a lot of happier women in the world, realistically. But back to what we were discussing earlier, every therapy has a placebo effect. So let's say a woman just, for whatever reason, isn't in a good relationship, or maybe she's been single for a while, or who knows. Is it bad or wrong if a therapy is done and she has placebo effect? And this ties into, I've had some women get this O shot, and they tell me it's the greatest thing since sliced bread, which more power to you. Scientifically, medically, I don't understand it. I'm not sure I believe it medically and scientifically, but hey, if it improved your sexual function, then more power to you.
It's a great point, Karyn. I think there's so much wrapped up in female sexuality, and really trying to understand what makes women want to have sex is probably something we should spend a whole lot more time investigating than trying to find this small location on, I think, the anterior vaginal wall. But I think one thing we could all agree is not myth in this space is the use of vaginal estrogen, and whether we're treating vaginal atrophy or genitourinary symptoms of menopause, it really works. And I think it would be fantastic if we could get everyone to immediately think vaginal estrogen when they heard the words vaginal rejuvenation. I think we would make a tremendous impact on women. It has so many amazing properties, and it can improve so many different things that women experience as they age, from vaginal irritation to burning to pain with intercourse to urgency, dysuria, urinary tract infections, recurrent urinary tract infections. I mean, there's so many things. And, the FDA recently lifted its black box warning on estrogen products, and now we can prescribe vaginal estrogen without having to explain to women about why this big warning appears when they go to the pharmacy to pick up their prescription. And I think this is really going to help women, and we should be really proud of the AUA and our other professional societies that have really supported that work to make it happen. And, only time will tell, guys, but I really hope that this lifting of the warning will translate to more prescriptions and more filling and more refilling of these prescriptions. And maybe we'll start hearing about estrogen instead of vaginal rejuvenation.
I think that's a great point. I will say I was at least told that it may take a year or more for the actual inserts to be taken out of the vaginal estrogen boxes, whether it be a cream, a tablet, or a ring. So I still have patients bringing in those inserts. So that there may be a bit of a delay until that actually happens, but it is exciting. I think one thing I see a lot, and I thought maybe I'd ask you about, is both with hormone therapy being systemic and with vaginal estrogen, I see a lot of women coming in who are being given testosterone, both vaginally in compounded creams with estrogen and also with their systemic hormone therapy. And I'm not quite clear, sort of that it's really standard of care, particularly if you're talking about systemic hormone therapy. So maybe if you want to comment on any benefits or risks associated with testosterone and why you might give it either vaginally or systemically.
So testosterone is not considered standard of care when you talk about typical hormone therapy. And what is interesting and what a lot of people do not realize is our androgen levels do not decrease the same as our estrogen and progesterone levels decrease. So what is kind of standard in your typical menopause therapy is if someone has complaints, just like for our male patients, decreased libido, decreased muscle mass, those types of things, it is not and if you check their testosterone level and it's low, make sure you also check other things that are pertinent to that, like your sex hormone binding globulin. If you give a woman 6 months of testosterone therapy and she does not improve, there is no point in continuing. I think there's pretty good evidence to support that. So while it's not standard, I have no problem if somebody wants to try it if they have a good reason and there's actually showing a decrease. But yeah, interestingly, our androgen levels really do not decline to the same degree. They actually stay pretty stable over time.
I'm seeing a variety of practices in the Philadelphia area. I think most commonly I see the OBGYNs prescribing standard menopausal hormonal therapy to postmenopausal women. But I do see a lot of women who are going out to seek more comprehensive care, holistic care. There's a lot of different terms being used, and a lot of them are specifically seeking compounded therapies. And I will see incorporation of testosterone into these therapies. And I've heard women, when I've asked them specifically about how their combination of medications has been determined, they'll say, oh, for my, I spoke to my provider about weight gain, and they thought the testosterone could help me with my weight gain. Or I've talked to my provider about interest in sexual activity, and they told me maybe the testosterone could help me there. I think maybe we don't really know, but to Karyn's point, I don't think there's a lot of evidence to support the practice. And it would be a great area for, really additional studies to try to understand if there is a role for some of these more challenging to treat components of menopause.
Yeah, I would agree. I think that's a whole nother podcast that can be done about treatment of menopause and what is bioidentical and what is not bioidentical. I also find that a lot of women who are given these formulations, and many of them are doing them with online consultations with some of these websites, they really don't even know what they're getting. They don't really understand what's in it. They just know that it's compounded or they're told it's bioidentical. But then when you try to ask them what's in it, they really are not aware. And so I'm not sure they're getting the right kind of counseling or shared decision-making as we've talked about.
But to your point, I think that is something that should be a red flag for us as physicians. When patients are so willing to go online to get what they are looking for. Look, if you prescribed a medication to a patient and you said, I'm not going to tell you what's in it, I'm just going to only give it to you online, they would think you were a quack. And yet people are willing to do this. And the question is why? And the answer is probably because we're not providing what these women need and or are looking for.
Yeah, I agree. And I think even more so, those of us that are trained in urology and are now subspecialty trained, we really didn't have training in menopause in a lot of these sort of endocrine gynecologic issues, and it's not being routinely addressed by their gynecologist. So like Karyn said, they're seeking it out elsewhere. And perhaps more of us in this subspecialty need to think about, getting certified as Karyn did and maybe, offering this treatment to patients. It's not something I do routinely in my practice right now, mostly because I just don't have the time or the support staff. I would actually be interested in doing it, but, it does require education and continuing education and time to talk to patients about these issues.
And I don't want to I want to get us back on our vaginal rejuvenation discussion, but just to your point, Nirit, I actually think that as urologists, we are probably more well-equipped to do hormone therapy because we are familiar with testosterone and the side effects. And ironically, that's actually the only hormone that you need to monitor any types of blood work for. And only a third of OBGYN programs have anything in their residency curriculum regarding menopause. So we're all at the same playing level. The question is, who is interested enough and motivated enough to help these women who are seeking these online treatments for their bothersome symptoms?
Yeah, in that same vein, as urologists, we are operating in the space of the gynecologic organs. We're often performing hysterectomies, oophorectomies, salpingectomies, but we aren't having those conversations with women about menopausal hormonal support after we remove those organs. I mean, this is really common among our urologic oncologists who are working in this space. And I think we need to make it part of our curriculum and part of our training to really understand how these hormones impact women, both when we remove organs and when we supplementally replace hormone therapy during menopause.
Along those lines, what would you say about the effects of systemic hormone therapy on the vagina? Is it enough, or do women often need additional vaginal treatment?
Yes and yes.
Yes and yes.
Yeah.
They need more. I think we also have some science to indicate things like incontinence may worsen, in fact, with systemic hormonal replacement. And it's something we need to make sure women are informed of. They may have a mild problem that gets a little worse. And we probably could address that with the addition of vaginally applied hormones or potentially other treatments for incontinence, but at least making women aware that these things may happen so they don't think it's a harmful side effect and a reason to stop using the hormones.
The only other question I had in terms of covering the topic of vaginal rejuvenation, because I think we've covered quite a broad array, is sort of two things. What do you think is the biggest misconception that patients have about vaginal rejuvenation? I guess that would be the first question.
It goes back to the very beginning of our podcast. I think the misconception is what vaginal rejuvenation is. I think that people actually think it is a specific procedure, and it is not.
Yeah, I think the biggest misconception is the claim to enhance sexual pleasure, right? That sex is going to get better. And this is where I think some women do get in trouble and start going and looking for things to do to themselves that are not founded to be true and could potentially cause harm. So we're surgeons, we're scientists, right? We want to offer women things that are going to definitively improve quality of life. And this is where the misconceptions that are out there that are easily found on Google and other websites for women are leading women astray.
So to your point, if a woman has a tightening, specifically she says, I don't feel orgasm or I don't feel enough, it's hard for me to orgasm because I'm too loose. Right, we have to tell her tightening you doesn't improve your sensation. But if you're like most women, who we derive a lot of our pleasure in life from helping and serving others, your partner may well derive more pleasure because you are tighter. And a lot of women are actually happy with that. But it is, a lot of people think that because you fix something anatomically, we can restore your sensation. Unfortunately, that is not true. But what is good is most women orgasm from clitoral stimulation. So that whether you have a vaginal rejuvenation or not, you still should be able to have good sexual function. I think if you understand, number one, what orgasm is, number two, really what in general, is the most sensitive sexual organ, which is the clitoris. But if feeling good about yourself or you're avoiding, it was really sad. I had years ago, a woman came to me because she wanted her clitoris, she said, was too large. And I expected on the exam to see like some clitoromegaly. She just had really redundant labia. But she had been with a partner who said, oh my gosh, you're ridiculous. Your clitoris is too big. So she never engaged in sexual activity for many, many years. And then she finally decided she wanted to take care of this. So for years, and with the internet, it was surprising she didn't look, but I think that there was so much shame and embarrassment that for years, this poor woman thought she had a problem or a different problem. And it's not that, making your labia, of course, is going to improve your sexual function or your sensation, but it does improve your self-esteem. So if you're avoiding sexual activity, then I think doing something like vaginal rejuvenation, whether it's cosmetic or not, is sometimes what people need. We don't necessarily condemn people to have plastic surgery. You want to look better. So I think we have to be very careful about understanding people's motivations, just like why they go online to look for these things. You two on this call know we don't have enough women who are advocating for women, and we certainly don't have enough women who are capable of actually fixing a lot of the things that women would like fixed.
Yeah, I agree.
You always drive it home, Karyn. I mean, that's exactly right. And this is where we may be able to collaborate with some of the advocacy groups who really are dedicated to improving the general health and overall well-being of women, and really try to improve messaging around what changes in our genitalia can be expected with aging, what things can be done to restore things that bother you. Just like cosmetic surgery, if something bothers you and it's making you not have sex, it's going to affect your life and your relationships. And these are things that can be addressed. They may not fall under the nice category of medical vaginal rejuvenation versus cosmetic, but these lines are blurred, and these lines are complicated to draw because there is so much interrelationship between how our anatomy looks and how we feel.
To add to that, I think what's also important, though, is if someone is seeking something like this, please just don't go online and find whoever's on sale or whoever is, touting themselves as a self-proclaimed expert. It always amazes me that people will do more homework looking for fabric for their couch than the actual reputation and training of their surgeon. And you see the patients come to you and they've had just a botched surgery, and you're trying to fix it. In your mind, you're like, why did you think that, this person was capable of doing this complex procedure for you?
Yep, that's a valid point. Another question would be, is there a right time or age to do these procedures? If you have a really young woman come to your office, let's say she's had one baby and she now has some laxity complaints or other complaints, is it better to wait until she's done with childbearing? Is there a timing of when things should be done, or how would you counsel a young woman?
I think the role of pelvic floor physical therapy for young women shouldn't be overlooked. This is something that so many women could benefit from. I know we have a pilot program at our institution where we're trying to funnel as many women as possible into pelvic floor physical therapy after childbirth, even if it's for a singular session, but just to raise awareness and allow people to better understand the changes that happen to their body and what they're capable of doing for recovery. But I think for me, if I met a young woman after one vaginal delivery, I would really encourage pelvic floor physical therapy as a first next step.
I would love to see us, or more of our OBGYN colleagues, start sending women to pelvic floor physical therapy before childbirth. Our IU run, everybody exercises on this call or this podcast. When you're in better shape, when you get injured, you're going to recover faster. I think we have a really unfortunate attitude in medicine. We're more reactive than proactive. So in a lot of countries, so my son tore his ACL a couple years ago. You do pre-PT now. You start doing your exercises before your surgery, so you're in the best shape possible. And I do think we have got to start getting women to do these things before birth. And I think an important point to make is if this woman has just had her first baby, I think it's better. Pelvic floor physical therapy is perfect because I think before doing anything surgical, she should probably complete childbearing, especially if it's for tightening or something like that, unless she is perfectly willing to have completely elective C-sections next time around. But even then, you never know what pregnancy is going to do. So if you're going to do a mommy makeover, the whole thing, just finish childbearing and see what needs to be repaired. Just do it all at once.
Yeah, I think those are great points. I think we've covered most of what we wanted to cover, unless either of you have any other comments you'd like to make about vaginal rejuvenation, but I think we covered it pretty comprehensively.
Yeah, I mean, Nirit, you did a fabulous job covering all the topics. I'm curious just to hear from you, since we did so much talking. In New York, I mean, do you get any pushback when you prescribe things like vaginal estrogen or pelvic floor physical therapy as therapeutic interventions? Are patients happy with that, or are they looking for more and for some of these procedures that we've deemed?
Maybe it's because of the nature of my practice. I'm not getting large numbers of women coming for necessarily just labiaplasty or more of the aesthetic vaginal rejuvenation procedures. I think a lot of what I see is functional and quality of life issues, probably like you see in your practice. Just like any big city, we have lots of people who are treating these issues, whether it be plastic surgeons, gynecologists, concierge physicians. There are some physical therapists in New York who are actually doing treatments. They're fitting women with vaginal devices for stress incontinence. So there's all kinds of providers out there, and probably that gets back to Karyn's point that there's just such a large demand and need, and there are not enough providers to fill that role. But I think in general, I don't get any pushback. I think, we all use physical therapy quite a bit at all ages, by the way. Vaginal estrogen is something I've been prescribing my entire practice, even with all the years of the warnings that you had to take the time to educate the patient. I think now that they're going to lift those warnings, it's going to get hopefully much easier. And I've actually had a few colleagues, general urologists, reach out to me asking if they should be prescribing vaginal estrogen and is there a reason not to. And I basically said, you should be prescribing it to any woman with vaginal symptoms, recurring infections, all the things we talked about. So hopefully that's going to become more commonplace even amongst people who aren't subspecialty trained like us. I do a fair amount of labiaplasty as well, and I think patients that come to me are sort of shocked that I tell them that most of the time it is covered because most of the patients I'm treating actually have physical symptoms, as we discussed, chafing, it gets in the way, pain with sex. I actually had a few women who have neurogenic bladders and self-catheterize, and as they age, the labia enlarged quite a bit and it became problematic for them to catheterize. So there are interesting indications for that. There are some things I don't do. Obviously, I don't do liposuction. I don't reduce the mons pubis. But I will say, getting back to the mommy makeover term, I've had a lot of young women come to me with prolapse or incontinence, and I often have them see plastic surgery, and we often work together if they want to do an abdominoplasty at the same time, or some liposuction or things like that. And that's where I've seen a lot of satisfaction from patients because they don't expect that they can have those procedures done concurrently in one surgery. And they're really appreciative when you offer that.
Yeah, I agree.
I think the title of our podcast was about myth versus reality. And I don't know, I think for me, vaginal rejuvenation is definitely a reality. Women are talking about it. Women are doing it. I think we talked about the things that were potentially myth, but do you guys agree with that? And do you think this is a term we can use with more positive connotation and try to rid it of its negative connotation?
I never thought it had a negative connotation. I just think it had a lot of confusion associated with it. Because again, people just didn't really know what vaginal rejuvenation was. And, for many years, that's like my favorite responses was, well, prolapse repair is vaginal rejuvenation with a medical indication.
Yeah, I agree. I think we've kind of proven that it's less myth and more reality, and that there are real reasons that women are seeking this care. And as we said, there's a whole umbrella of procedures that would fall under this, including prolapse and incontinence repairs. So hopefully we can set the record straight for people.
I always find it fascinating being a urologist and doing what we do. Has there ever been controversy about, or as much, public controversy about penile lengthening, injections to make the penis, wider? That's just kind of a fact of life. Like if you want it, you do it. No one would be judgy about it. But yet if a woman wants to make her vagina more sexual, whether it's appearance or functional, we're like, what are you doing? Why are you doing vaginal rejuvenation? And I do think we need to stop having so much of a double, no, listen, we're opening a whole other like podcast or book, but society, but there is a double standard. And I think that being urologists who practice urogynecology, I'm sure you two have seen how much there is such an inequity, whether it is hormone therapy. Men with prostate cancer, we give them testosterone all the time. Nobody bats an eyelash. But you want to give a woman some vaginal estrogen, even though the data shows that it doesn't get absorbed systemically because there's a black box warning on it. There's a black box warning on quinolones, I think, and that doesn't stop us from prescribing them. So I think we need to be a little more open-minded. I think we have to also help our female patients understand that there are many things that are done in medicine off-label. Everything comes with the risk. It's a matter of seeing your provider who can help you understand those risks and together make the choices that help you have the most satisfying life, vagina, sexual function, whatever word you want to fill in the blank with.
Yeah. And I think the other thing I'll add to that is we've now proven that people in our field as advocates nationally and at the FDA actually got something done. So it's worth learning how to advocate for our patients and improving what we can offer them.
I think if this spins off another podcast, we've done a great job.
Agreed.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.